Thank you, Dr. Cohn. The meeting is now gavelled open for the afternoon session. We will begin with the coronavirus disease 2019 COVID-19 talks, and we'll start with the overview of COVID-19 disease by Dr. John Brooks. Dr. Brooks, thank you for being here. Please proceed.
Terrific. Thank you so much for that. And I'll wait for the first slide to come up on the screen here. A lovely view of our building at CDC right now. There we go. So I'm John Brooks. I'm the Chief Medical Officer normally in the Division of HIV/AIDS Prevention, but I'm acting as the Chief Medical Officer for the COVID-19 response. And I'm really pleased to have this opportunity to speak to you. I don't have any relevant financial affiliations to disclose. And let's start by talking about some of the background virology around COVID-19. And before I continue, I'll just note that the slides that were sent out earlier, there are a few of them that I won't present here today in the interest of time, but you have them as backup. And if you have questions about them, please reach out to me. I'll be happy to explain. So move on to the next slide, please. And the next slide, please. Excellent. So basic structure of the virus. This is a single-stranded RNA virus, has a genome of about 25 to 32 kilobases. That's relatively large in the world of these kinds of viruses. It's also a relatively large virus, period. This family ranges from 65 to 125 nanometers. The key thing that you need to know about the structure is that it's composed of 4 principal proteins, the most important of which is the spike protein, a trimer that's on the outside of the virus. Inside the virus is the RNA genome surrounded by a nucleocapsid, and then there are 2 other proteins, a membrane protein and an envelope protein that are in the envelope of the virus. You'll probably hear more about this later on. Next slide, please. Here's a micrograph, Electron micrograph of an actual coronavirus, the star of our show today, albeit this is not SARS-CoV-2, but a good stand-in, good example nonetheless. So smile, you're on candid camera right now. Next slide, please. So let's talk about the family of nidovirales to which this virus belongs. Nido comes from the Latin word for nest and refers to a hallmark of nidovirus transcription, also seen in all coronaviruses, namely that the synthesis of the 3' coterminals is a nested set of mRNAs. So they're kind of nested together. And if you're not a virologist, don't worry, this will not be on the test. But I do want to emphasize that coronaviruses comprise a very large family of viruses that infect a wide variety of mammals and birds. They're divided into 4 genera shown at the very bottom on the left, alphas, betas, gammas, and deltas. The alphas and betas infect mostly mammals, and these are the 2 genera that cause human disease that I'll cover in the next slide. They've also been isolated from many land mammals, as well as those that fly, like bats, and those that swim, like beluga whales. The gammas and the deltas mostly infect birds and have been isolated from birds across an entire spectrum of size, from sparrows to ostriches. CoVs cause a variety of lethal diseases in both mammals and birds, and for this reason have been well studied due to their impact on the agricultural sector, where they cause fatal illness in herds or flocks, usually in the form of respiratory or enteric illness. Next slide, please. So there are 7 known human coronaviruses called HCoVs for short. 4 at the top here are generally the cause of mild illness, mostly upper respiratory disease like the common cold. However, the 3 in the bottom are all serious human pathogens that can cause lethal disease. There are also all 3 beta coronaviruses. These include SARS-CoV-1, the cause of the 2003 SARS outbreak, MERS-CoV, the cause of sporadic clusters of Middle East respiratory syndrome, and now SARS-CoV-2. And just to be clear, so we're all on the same page, I want to make sure everybody understands that when we use the term COVID-19, that describes the illness that is caused by the virus SARS-CoV-2, because it's genetically more like SARS-CoV-2 than MERS-CoV. Next slide, transmission. Moving on, please. So COVID-19 appears to have first been recognized as a human illness late in 2019. We don't know exactly when, how, or where the virus arose, but we believe it represents a cross-species transmission from an animal reservoir, very likely bats, that may have involved an intermediary host, like its cousin SARS-CoV-1 and MERS-CoV-2, which you may recall used the palm civet cat and dromedary camel as intermediary hosts. But that's entirely speculative at this time. And you'll note on the diagram on the left that even during the earliest phase of the recognized outbreak in these early weeks of January, more than 35% of diagnosed persons didn't report a known exposure to the market where the disease was believed to have started, where the outbreak, rather, is believed to have started. And it may be that this market was simply a location that amplified a virus already circulating in the community. So by mid-January, COVID-19 had been confirmed in just about every province of mainland China, with the greatest number of cases in Hubei, shown in dark pink in this map, centered within the province's capital, the most populous city of Wuhan. Next slide, please. So this figure shows the daily number of new cases reported from China, shown in green, and from all countries outside of China, shown in yellow, since January the 19th. Early in the epidemic, spread of COVID-19 was limited mostly to China, with 2 large increases in mid-January related to a change in the Chinese case definition. However, as of February 25th, the daily number of new cases outside China exceeded those within China, and as of March 4th, the number of daily deaths from COVID-19 outside China exceeded those within China. Next slide, please. So after a brief pause, following resolution of the original outbreak in China, shown on the left side of this now larger diagram, starting in early March, COVID-19 spread rapidly worldwide. This is a slide from the World Health Organization, and you can see from the inset bubble map at the top left that it basically have been reported everywhere in the world, except for a few island nations, Antarctica and the International Space Station. And new diagnoses are continuing, unfortunately, to accelerate, shown by the figure on the right, with the largest expansion presently occurring in the Americas. And I just want to make an important note here. Look at the peak daily number. It was 188,000 in the last 24 hours, that most recent high peak. And that number exceeded in one day the total 115 cases reported worldwide during the 6-week period that China responded to their outbreak. So this is really moving quickly apace. Next slide, please. So I want to spend a little time on this slide to explain that despite the close genetic relatedness of SARS-CoV-1 and SARS-CoV-2, this new virus, SARS-CoV-2, differs from both SARS-CoV-1 and MERS-CoV in 2 very important ways. First, although the incubation periods are about the same, the serial interval for SARS-CoV-2 is shorter than its incubation period, and this means that infected persons can be infectious to others and transmit the virus before they develop symptoms, and that has not been observed for SARS-CoV-1 and MERS-CoV. And in fact, SARS-CoV-2, we have now observed that infections peak in the few days, the infectious risk peaks in the few days before symptoms come on and shortly thereafter. Second, we also now know that a substantial fraction of infected persons, estimated to be about 30 to 35%, never develop illness and remain asymptomatic. And unfortunately, we know that these asymptomatically infected people can transmit the infection to others, although how infectious they are to others compared to symptomatic patients is still being worked out. Next slide, please. Okay, this table shows what we know about which body fluids carry and can transmit SARS-CoV-2. And it's very clear that infections are transmitted through exposure to respiratory particles. Although viral RNA can be readily detected in stool, efforts to isolate the virus by culture have been remarkably unsuccessful, with only 2 reports suggesting possible isolation of live virus and many, many reports of failed attempts. Thus, if stool is a mode of transmission, it has not yet been epidemiologically confirmed. Urine and blood and other fluids to which infants might be exposed during birth, reassuringly, have not been shown to contain infectious virus. Curiously, detection of RNA has been confirmed in semen, but only in men during the peak of illness. After recovery, RNA appears to no longer be present, and neither isolation of live virus nor sexual transmission of SARS-CoV-2 have been reported. Next slide, please. So people often ask, how far can SARS-CoV-2 travel? And I just want to tell folks there is very strong evidence that this is transmitted like other respiratory viruses through respiratory droplets and other particles to which persons are exposed in close proximity to a source patient, about 6 feet or 2 meters. Small aerosol-sized particles comprise a large fraction of what comes out of our mouths when we speak, although when we shout and sing, the particles do get larger. I mention this because some of you may have read or know that under highly controlled experimental conditions, virus has been demonstrated to exist for hours in small aerosol-sized particles. However, there is no compelling epidemiologic evidence at this time that airborne transmission outside of the 6-foot respiratory droplet zone is a substantial risk for spread of virus. We have not seen examples of transmission, for instance, across large spaces, such as in restaurants or theaters, or infection in people whose only exposure was passing through the same space where an infected person had lingered but was no longer present, or transmission through air handling systems, such as in office spaces or cruise ships. On the contrary, SARS-CoV-2 likes ventilation, and ventilation is your best friend with this virus because it substantially reduces the risk of infection. Next slide, please. So I'd like to spend a moment talking about what we know about how humans respond clinically to COVID-19, and I'll emphasize 5 main points. Next slide, please. First is that after illness, onset viral burden declines steadily. Whether it's a respiratory sample or a stool sample, the quantity of viral RNA is highest at illness onset and decreases steadily thereafter. Next slide, please. Second, as viral burden declines, as shown in the upper figure, the ability to recover live virus from human samples by culture becomes more difficult. After 8 to 10 days, replication-competent virus can no longer be recovered from respiratory tract specimens in a number of studies now, and this is in otherwise healthy persons with mild to moderate illness. There is a recent study that suggests that in severely ill patients and in persons immunocompromised from bone marrow transplant and organ transplant, shedding of cultural virus may persist up to 20 days. Third point, shown here in the bottom half of this slide, is that within days after symptom onset, and as viral burden and recovery of cultural virus decline, patients begin to develop a serologic response to infection. And I can tell you this includes IgM, IgG, and IgA, and that the IgG response includes neutralizing antibodies. And I think Natalie may talk about this in more detail later. Next slide, please. Fourth, in addition to a time limitation on detection of live virus and infectiousness, it's also evident that ability to culture the virus from specimens declines with decreasing viral burden. It's really remarkable how across a number of different studies now, looking at how long virus can be cultured, there is almost universally some threshold of viral burden below which virus is no longer able to be recovered, usually in the range of what's called a cycle threshold of about 30 to 35. But this also depends a lot on the primers and PCR setup being used and may differ between laboratories. But the point here being that there is a viral burden below which it becomes there is no evidence that you can culture the virus. Next slide, please. And my fifth and final point is this. It is very interesting and novel for this virus is that it's been shown and widely observed that viral RNA can be detected by PCR and remain positive for weeks, long after a person has fully recovered from illness and after we believe people are no longer infectious. So shown here is an illustrative curve from a paper by Zhao et al. That illustrates the classic reverse sigma shape you see with this kind of phenomenon. And to date, for your information, the longest persistent positive has been documented out to 12 weeks at 83 days. So this phenomenon, as I noted, is not observed with SARS, not observed with MERS, and it has created a substantial problem for patients for whom isolation is discontinued or transmission precautions are removed based on a test-based strategy using PCR testing. And clinicians are increasingly managing patients who can't leave the hospital, can't get back to work, or can't get back to other activities of our new normal of life because they're stuck in what I'm calling persistent PCR purgatory. And I just want to reassure the folks listening that we're actively working to review all available data and anticipate that we'll shortly amend our current test-based strategy that requires 2 consecutive negatives to remove precautions. Next slide, please. All right, a little bit about the clinical epidemiology of this illness. Next slide, please. So to give you a sense of the relative frequency of the major signs and symptoms of COVID-19, I'm showing here these early data from reports of hospitalized patients in different parts of China. And you'll note that more than 80% develop fever during illness and over half develop cough, about 25% myalgia or arthralgia, and a small fraction in the 10 to 20% range have headache or diarrhea. Most people present with subacute or acute onset of cough and fever. I want to note that the fever may be measurable at presentation, although many people describe sort of a prodrome of feeling feverish but don't have a measured fever. And at presentation, only 44% of people in one study had a measurable fever, but most will go on to develop one. And I also want to highlight that there are some interesting reports that there are patients who presented first with GI illness, so with abdominal discomfort and diarrhea, that preceded the development of cough and fever by a day or two. Next slide, please. Unfortunately, at this time, there's no set of signs or symptoms that are related to, or other related clinical findings that can reliably discriminate COVID-19 from other respiratory viral illnesses like influenza. I do want to point out, though, one very interesting aspect of COVID-19, which is the relatively high frequency with which infected persons have reported anosmia and dysgeusia, or any other change in their sense of smell or taste. And sometimes this has been their only symptom of illness. These frequencies have ranged from 30 to as high as 70% in one Italian cohort, and when present, can be highly predictive of infection if SARS-CoV-2 is circulating in the community. As I noted earlier, most people will recover spontaneously with supportive care, but for those who don't, the typical complications are like those seen with other viral respiratory infections: pneumonia, respiratory failure, multi-organ system failure, and death. Next slide, please. This is an illustration to show you a little bit about the severity of illness in adults versus children from 2 large studies early in China. In general, most adults who are symptomatic will experience mild illness and recover without complications, although there's a very substantial fraction who develop severe or critical illness, and among those with critical illness, about half died. In contrast, the disease is considerably less severe in children. Less than 5% in this cohort develop develop critical disease or severe disease during infection, and a very large fraction were asymptomatically infected. And I just want to remind you that these studies were done before we recognized the true frequency with which infections remain asymptomatic, which I noted before is around 30 to 35%. And I just want to also highlight that we now also know that with increasing age, infection is less likely to be asymptomatic. The peak viral burden that a person experiences is likely to be higher, and the duration of RNA shedding appears to be longer. Next slide, please. Okay, high-risk groups. You've probably heard that there are certain underlying medical conditions, chronic conditions, comorbidities that increase the risk for severe illness and death. I also want to note that advancing age does the same. I've removed a slide about age in this for the interest of time, but you can go back and look at it. But once people get over the age of around 40 to 50, there's a steady increase in the case fatality rate. And the fraction of persons who die is probably related to the age structure of the population. Higher the average age, the larger the CFR. Also, reassuringly, immunocompromised persons, the data seem pretty good right now. Other than for persons with acquired immunodeficiency from HIV, we haven't really seen a strong signal of risk in this country, although we continue to expect that people with a low CD4 cell count or not virally suppressed could fare worse. And likewise, interestingly, there's no definitive evidence that cancer therapy worsens outcome, including immunosuppressive cancer therapy. Next slide, please. So I want to spend a moment talking about these extraordinarily unique and troublesome and worrisome complications of COVID-19. And there are 3. The first is that this infection seems to cause a diffuse endotheliitis, where there's a viral tropism that it infects the endothelial cells that line our arteries and veins and causes inflammatory cell injury and death. And this is seen across many different tissues in autopsy series. Second is this problem with hypercoagulability that's been observed in vessels of all sizes and in veins and venules predominantly, but arteries, arterioles, and capillary beds as well. Autopsy examinations have demonstrated that clots include both those that form locally within a vessel, typically veins, as well as clots that may have traveled into a blood vessel as a thromboembolus. And I want to point out a particular concern here are these pulmonary emboli, where a number of autopsy series have shown that despite aggressive anticoagulation, people recognize this as a problem. Despite aggressive anticoagulation, in 2 autopsy series, PE was almost universal in about 24 patients and was deemed by the pathologist as contributory or the likely cause of death, but it was not recognized in life. And then lastly, I want to highlight something that may be of interest to folks as you think about a vaccine, and that is these peri and post-infectious hyperimmune reactions. In adults, one of the most severe is a myocarditis. We're seeing ST elevation MIs, but when they do coronary cath, there's no blockage. And it looks like the rise in enzymes is from a diffuse injury to the entire heart muscle. And in children, you've probably heard about this syndrome, which can in some kids occur about a month after they've been exposed or infected, of multi-inflammatory syndrome that looks a little bit like Kawasaki's, but is actually a very distinct entity from that. Next slide, please. So in closing, I just want to talk a little bit about what we know about SARS-CoV-2 and influenza co-infection. And these are data from a study in Wuhan involving 307 patients. The data were collected in January and February, which is typically the peak, as you know, of influenza in the Northern Hemisphere. Patients were from a single hospital. Diagnoses were made as shown here. And I'll just note that in the 3 groups, either mono SARS-CoV-2 infected or co-infected with flu A or flu B, there were no significant differences in these groups in terms of age. Most people were in their 50s or 60s. In sex distribution, there's an even number of men and women, and in illness severity at presentation. Now, although the number of co-infections with flu B was small, and that's, I think, what we would expect in a typical flu season. If you look to the right at the number of patients who died, those that were co-infected with flu B died at 5 to 6 times higher percentage than those who had either monoinfection with SARS-CoV-2 or co-infection with flu A. I'll just note that in this study, the flu B co-infections were mostly concentrated in the first 2 weeks of January. And there's the possibility that what we are seeing here is people learning how to better manage COVID, and they were succumbing to COVID rather than to the co-infection. But if that were the case, I might have expected that the monoinfection with SARS-CoV-2 could have had a little bit higher percentage of death. Nonetheless, I think this is really an important warning to pay attention to and emphasizes what I'm telling everybody this year, that I don't care if you think the flu shot is something you're never going to do in a million years. This is the year that you got to do it. Next slide, please. And then lastly, I just often asked what I think is going to happen, as I think many of us are, and I don't know what's going to happen, although frankly, the current trends we're seeing today and yesterday are disarming, but this is what I do know. First, that this infection is nothing like influenza. Secondly, that this virus is not like any human coronavirus we've seen before. And thirdly, it is causing a unique and serious and very disturbing set of clinical and epidemiologic problems that I don't think anyone would have ever expected. So simply put, this is an entirely new disease. It's a very bad disease. And that's why we urgently need a vaccine or some other form of effective preventive therapy. And I wish the ACIP the very best. Over.
Dr. Brooks, thank you very much for that very instructive overview. Unless Dr. Cohn has any objections, we will open this up to questions at this time. Amanda, is that okay?
I think we can open this discussion up for a couple of short, quick questions for Dr. Brooks.
Okay, let me exercise Chair's prerogative and ask the first question or questions too. So, do we know today? Do we have a better estimate today of the percentage of children infected that have asymptomatic infection? And second of all, do we know anything about their viral loads during the acute infectious period as compared to adults?
Yeah, I'll have to say, first of all, unfortunately, I'm an adult clinician. I sometimes forget to pay attention to children. My colleague who follows is going to be presenting some U.S. data, and there may be some data in there about children. What I can say is this, that in terms of the frequency with which children appear to get infected, it's interesting. Most reports seem to show that when you have children equally exposed to adults, let's say they all have the same level of close contact, that the incidence of infection may be a little bit lower in kids. That's not universally been the case. There's been some studies that suggested it might be the same, but there also are a lot of reports that suggest they may be less prone to infection or less likely to have, if infected, less likely to test positive by PCR. And in terms of viral load or time to resolution of PCR positivity, I'm afraid I don't know the answer to that.
Thank you. I see that Ms. Dries has her hand up.
Yes, thank you. This is Marcy Dries with Shea. I just had a question with or about co-infections. Early on, as we were starting to test for COVID, we could only get a COVID test if someone tested negative or RSV. And then as we moved on, because the flu positivity rate declined so precipitously, we stopped testing for flu and converted over to COVID testing. So I feel like we don't really know a lot about how common co-infections even are in this country. And we've been presuming that they're uncommon, but I just wanted to know if you had any further information on that.
Yeah, I mean, part of this is a function of timing, that flu season was beginning to decline as the new COVID epidemic in this country began to grow. But I will say these Chinese data, I didn't expect this, that they would see this amount of co-infection. I think what may have been happening is they were at the peak of their flu epidemic, and then COVID kind of stepped in. And so there's a lot more opportunity for co-infection. And I wouldn't discount that the possibility of co-infection exists at all. I believe our lab, and Natalie can comment perhaps, is developing now a PCR test that's a multiplex retest for flu A, flu B, and COVID-19. So hopefully that'll give us a much better perspective on the frequency with co-infection occurs, so we can also monitor clinical outcomes.
We have a question from Dr. Paling.
Hi, Dr. Brooks, thank you for a very informative talk. It's been really interesting to hear. One of my questions is, do you have any data from China about co-infection with RSV? Children have a large burden of RSV infection, and I just wanted to know if there's any information for that co-infection.
A fantastic question. I don't know, but I'm putting that on my list to go search for tonight.
Are there any other questions? Okay, let's move on to the next presenter. It's please Dr. Thornburg, who will talk about SARS-CoV-2 immunology.
Hi, thanks. Yeah, I'll go through about the next 15 minutes talking about what we've learned about immune responses to SARS-CoV-2 in the past several months. So next slide, please. Okay, so this is an outline of the points I'm going to be highlighting. I'm going to talk about what do we know about immunity to coronaviruses in general. What do we know so far about SARS-CoV-2 immunity? I will touch briefly on how we test for antibody immune responses to SARS-CoV-2, and I'm only talking about antibody responses today. I will give you some brief updates on severity of diseases and antibody responses and antibody kinetics that were recently published in the past 2 to 3 weeks, and then I will touch on some conclusions. Next slide, please. Okay, John already talked about the different kinds of coronaviruses, but broadly they can be divided into common coronaviruses, which cause colds, 229E, NL63, OC43, and HKU1, and then the uncommon coronaviruses, SARS-1, which of course is not circulating anymore, and MERS, which is circulating but in a very limited form. Next slide. It's difficult to extrapolate what we might know, what we know from SARS-1 and MERS, extrapolate that to immunity against SARS-2 because they're so rare. So we may need to take a note from what we know about immunity against the common coronaviruses, which is unfortunately not a lot, but we do know a little bit about immunity against the common coronaviruses. So in the common coronaviruses infections, we know that there is protection, but protection can be transient, and that waning serum neutralizing antibodies may contribute to susceptibility to reinfection. There are 2 papers that I've discussed here. One about the 229E human challenge model that was performed in the late 1980s, early 1990s. And in this study, they challenged 15 volunteers were inoculated with 229E. And the 10 volunteers with lower serum antibody titers became infected, and only 8 of them developed colds. Now, presumably, these were all adult volunteers, so they probably had baseline serum antibody titers and cellular immunity against the virus. And then 1 year later, they did a re-challenge of these 10 individuals who became infected, and 9 became reinfected as assayed by virus shedding. However, none of them developed cold. So it seems like even if they didn't have a sterilizing immunity, many of them had some immunity that protected against symptoms. There was a household transmission study published in 2018 out of the Noakes lab in Kalifi, and they found in the households 2.5% of household members had an NL63 infection. Most of those individuals only had 1 infection in the 6-month study. They then looked for repeat infections of all the common coronaviruses, and they saw repeat infections in 21, 5.7, 4.0% respectively. And those were all more than 90 days apart, so that there was at least short-term protection against reinfection. A minority of the repeat infection exhibited higher viral titers, so most of the second infection exhibited lower viral titers. Next slide. So it's been a few months now, and we have had many people, we have been able to characterize at least short-term immunity against SARS-CoV-2. Want to ask the question, does SARS-CoV-2 immunity resemble common coronavirus immunity? Next slide. So what we've been able to determine thus far is that most COVID-19 patients mount IgG and IgM responses to the virus. Many of the patients mount neutralizing antibody responses. So they mount an antibody response that's able to block virus from binding its cellular targets. And that the magnitude of the antibody response correlates to disease severity. So in general, the more severe the infection, the stronger the antibody response. Next slide. What we don't know, and this is just a list of things we don't know yet, are COVID-19 patients susceptible to reinfection? Are antibodies a correlate of immunity? It is likely that they are, but we don't have an absolute correlate of immunity yet. And if so, what is the quality? Is there an isotype that contributes to immunity? What antigen do protective antibodies bind, and what part of the proteins? And are they neutralizing? Is there a threshold of protection? So is there a level of antibody needed to protect you? And if so, how long will serum antibodies last, and how long might they stay above that threshold of protection? Next slide, please. So we can use kind of two broad categories of antibody assays to detect antibodies. One, binding, and two are functional assays. So the binding assays used tend to test for antibodies against either the spike protein, which John showed in his cartoon, or the nucleocapsid protein. And there's three different versions of the spike protein used in assays, and the spike is the target for neutralizing antibodies. Nucleocapsid is abundant during viral replication. And then tests can either test for total Ig or pan-Ig, which detects any immunoglobulin, IgG, IgM, or IgA. Next slide, please. So this is a structure of the spike antigen that was determined by the Jason McClellan and Barney Graham at NIH, and it is a trimer. It is a massive protein that is divided into the S1 region and the S2 region. It's got a receptor binding domain that is shown in green, and then it's got a stock domain that's the S2 domain that's shown in red, orange, and yellow. And each protomer is shown in a different color. One protomer is white, one protomer is gray, and the other protomer is colored. And it is metastable and exists in a prefusion and a postfusion complex, or conformation. Next slide, please. So this is a zoomed-in picture of a single protomer. So 3 of these makes up the entire spike protein on the virion. And I mentioned earlier, there's sort of 3 different versions of the protein that are used in antibody assays. The receptor binding domain, or RBD, which is just that small green part, and that is the part that binds to ACE2, the cellular receptor for SARS-CoV-2. S1 is used in multiple assays, and that is the receptor binding domain with the N-terminal domain, shown there in blue. And then full spike, or spike ectodomain, or S2P, is the receptor binding domain and the N-terminal domain, along with the S2 domain, which I've circled there on the right. Next slide, please. Now, you may have seen in the literature that there is a variant that has emerged as the more dominant circulating variant. And that has a coding mutation in the spike protein at residue 614. This is a structure that I pulled off of the web of the spike protein. This is in its trimeric form. This one, the receptor binding domain, is shown in red, and the N-terminal domain is green. And the D16 residue is zoomed in there, and it's kind of right at the S1 and S2 interface. It is away from the receptor binding domain, but is kind of near the fusion machinery. Thus far, individuals who have tested the ability of serum to neutralize this new variant. Haven't found differences between the original circulating variant and the 614G variant. However, it could, in theory, escape some antibody responses. Next slide, please. A benefit, so this is the nucleocapsid protein, which is also a target for antibodies and used in antibody tests. It's beneficial. It's not the target for neutralizing antibodies. However, it's easy to produce in large quantities, and it's abundantly expressed during early infection. So it's a very sensitive assay. But a con in using this is that it's unlikely a target for neutralizing antibodies. Next slide, please. This is just a list I pulled off of the FDA website of approved assays or assays with EUA authorization, the companies that make them that have been approved as of last week. So you can see the different companies that are making antibody assays and the isotypes they're detecting. Several are detecting total IG, some are IgG, and then some separately IgG and IgM. A few target the nucleocapsid protein, some the S1, and then some both S1 and S2. And this is the listed sensitivity, positive agreement or sensitivity, and then negative agreement on the right. And I've listed the percent agreement, and then in the parentheses are the number of specimens the company used to validate their assays. Next slide, please. So that's a summary of the binding assays that are used to detect any antibodies that bind. But in addition to that, there's several different ways to detection functional antibodies. And this is just a general list of the kind of neutralization assays that labs and clinics are using to detect antibodies that neutralize the virus. So you might see plaque reduction neutralization titers, which is a classical test where serum is mixed with virus and you see how much serum is needed to stop production of plaques or holes in the monolayer. Clinical isolate microneutralization, where you take isolates made from patients, and then you see how much serum is needed to completely block virus-induced cytopathic effect. There are some groups who are using infectious clones, so these are used in containment. They are fully infectious viruses, but they have a reporter gene, like a fluorescent gene, inserted into the genome so that you have a fluorescent outread. Focus reduction assays, a little bit like plaque reduction neutralization, but you do an immunostain for a viral protein, and that's a little bit faster than a plaque reduction assay. And then pseudoviruses are being used widely in vaccine trials right now because they can be done at lower containment at BSL-2. And you take the backbone of another virus and you put the spike protein on the surface, and it usually has a reporter gene in it as well. It's faster, it's easier to do those since it's not in containment, but they can be a little less a little more sensitive than live virus neutralization assays. Next slide, please. Okay, so what do we know about antibody responses thus far? So we know that this is from the Lancet from a couple months ago, and the top panel is from, the left panel are from severe cases, and the right panel are from mild cases. And what you can see is that the severe cases, the lines are sort of shifted to the left, meaning antibody responses are detected earlier than in the mild cases. So more severe patients exhibit more robust and faster antibody responses. Next slide, please. We know that a majority of hospitalized COVID-19 patients develop neutralizing antibody responses. This is from a recent article out of Emory from Mehul Suthar and Jens Rammert. And just look at panel A, and that's the neutralization titers from hospitalized coronavirus patients versus healthy controls. And all but 4 of them had detectable neutralization titers, although the titers ranged quite widely. Next slide, please. This is a study that was published or is in preprint form on medRxiv right now, looking at patients with milder infections and neutralization titers at different time points, at discharge and then during the convalescent period. And this is using a pseudovirus neutralization assay, and they have found that 30% of the patients in their cohort have titers less than 500. So 30% of patients with mild infection had low neutralizing antibodies at discharge. And they saw at discharge, between discharge and their revisit of 47 patients that they had revisit, they saw no major changes in the neutralizing antibody responses. Next slide, please. What they were able to correlate is that older patients had higher neutralizing antibody titers. So you can see them grouped by age group in the left panel, and then a correlation in the right panel, and some correlation of age and higher neutralizing antibody titers. Next slide, please. Most of what we know about SARS-2 immunology are from hospitalized patients, but what about milder infections? Next slide, please. So we did a study from some sailors on the USS Teddy Roosevelt, and both their binding antibodies and then their microneutralization titers. Now, we used a microneutralization that requires full neutralization of the virus, so it's kind of a high bar. If we used a pseudovirus assay, they may have had higher titers, but we found that 41% of these healthy, young, healthy adults who had antibody responses did not have detectable neutralization titers. Next slide, please. And this is a study that was just published in Nature Medicine last week, where they looked at asymptomatic and symptomatic patients at acute and convalescent time point. And the convalescent time point was 8 weeks after discharge. And what they found was a decay in the acute and convalescent time points in both the asymptomatic and symptomatic patients, both in binding antibodies on the left side and in neutralizing antibodies on the right side. They were still above the limit of detection, mostly still above the limit of detection of binding antibodies, but neutralization titers did drop below that 50% threshold in a large number of the symptomatic patients. Next slide. So this is just my conclusion slide. We know that most SARS-CoV-2 patients mount serum antibody responses, and even mild cases of SARS-CoV-2 can result in development of antibodies. But the magnitude of antibody response roughly correlates with severity, which is consistent with what we know about other coronavirus infections. A portion of individuals with antibody responses may not develop serum neutralizing antibody responses, and by 8 weeks after discharge, a portion of patients have dropped below the 50% inhibition neutralization threshold. And that is, next slide, that's the end of my talk. Thank you.
Thank you very much for that presentation. We will take a couple of questions here from the voting members first. Dr. Fry.
Thank you. Thank you for that great talk. I had two quick questions. I was wondering, is there any reason to believe that there's an antibody-dependent enhancement phenomena that is going on, and if so, to what proteins would be the culprits? And then my second question is there evidence that some of the common coronaviruses, such as OC43, were once very virulent, and that we might go that same route with COVID-19 virus, SARS-CoV-2?
So to answer your first question, I don't think we have any data yet to suggest antibody-dependent enhancement of infection. We're 6 months in now, and I don't believe that we have had any evidence of someone with an antibody response who then goes on to have a more severe infection if they get a second infection. So the answer, I don't want to say no because it's still early, but not yet. And to answer your second question, I do think that immunity is going to be similar to SARS-CoV-2 as common coronavirus infections. I don't know historically what the emergence of the common coronaviruses look like. I don't think it was quite as severe as emergence of this particular coronavirus infection, but I do suspect when they entered the population that it was as infectious as this coronavirus.
Thank you.
Dr. Lee.
Thank you for that excellent presentation. You had presented earlier during your talk about common coronaviruses and the antibody responses that we're seeing. I was wondering if there was any historical data on whether or not those antibody responses were dependent by age. So clearly by severity of disease, at least with the newer coronavirus. But from historical data, do you have a sense by age or by risk condition if there are any differences in levels?
No, we don't have that kind of data because they are common. So it's like a lot of other upper respiratory virus infections in that those are mostly diseases of childhood, and we get them by the time we're 2 to 5 years old, and then we get repeat infections during life, but they are something that we have already seen. So it's complicated by the fact that we have memory B cells against the virus and memory T cells. So we don't have that kind of data because they are so common.
Thank you.
I don't see any other questions from the voting members. Anybody from the liaison groups? Dr. Cohen, are there any? I don't see any. Okay. Then let's go forward to the next presentation. Dr. Oliver, who will speak on U.S. COVID-19 epidemiology. Dr. Oliver, please.
Thank you. Good afternoon. So first, I'm going to present an overview of U.S. COVID-19 epidemiology, and then epi among specific at-risk populations, and finally, a brief review of serology studies. So as of June 23rd, a total of 2.3 million cases have been reported to CDC, with 120,000 deaths. This map shows the cumulative case counts by county, with the darker red representing the larger number of cases. An MMWR was recently published describing COVID-19 case surveillance through May 30th. Through that time, there was over 1.7 million cases reported to CDC, and hospitalizations were 6 times higher among patients with reported underlying conditions, and deaths were 12 times higher. Several clinical outcomes varied by sex. Males were hospitalized, admitted to the ICU, and died at a slightly higher percentage compared to females. This figure is from the recently published MMWR, showing cases of COVID-19 by date of report to CDC. The 7-day moving average, as shown by the blue line, peaked on April 12th. And while there has been a decline since then, the 7-day moving average indicates ongoing community transmission. This figure shows COVID-19 associated deaths through May 30th, and the 7-day moving average number of deaths peaked on April 21st. This graph shows the number of specimens tested for SARS-CoV-2 using a molecular assay and reported to CDC by public health laboratories. The number of specimens tested are in the bar graphs, and the percent positives are shown in the line graphs. This past week, the overall percent positive at public health labs was 5.5%. The number of specimens testing positive has decreased since the initial increases in April. And in addition, while the number of specimens from children tested is low, representing less than 5% of specimens tested, the percentage testing positive in this age group is higher than in the adult age groups. This figure shows the specimens tested and percent positive among commercial labs reported to CDC, with the overall percent positive at 6.7%. The percentage of laboratories specimens testing positive is low, but has increased slightly in the past 2 weeks of reporting. Visits to emergency departments are monitored through the National Syndromic Surveillance Program, or NSSP. To track trends, visits for influenza-like illness, ILI, or COVID-like illness, CLI, are monitored in a subset of emergency departments in 47 states. In the week ending June 13th, 1.7% of emergency department visits captured in NSSP were due to CLI, and 0.6% were due to ILI. Levels of both ILI and CLI increased in late March and then declined. The National Center for Health Statistics, or NCHS, collects death certificate data from vital statistics offices for all U.S. deaths. Through the week ending June 13th, 7.1% of all deaths were due to pneumonia, influenza, or COVID-19. This is the 8th week of a decline. However, the percentage remains above the epidemic threshold. The COVID-19 Associated Hospitalization Surveillance Network, or COVIDNet, conducts population-based surveillance for laboratory-confirmed COVID-19 associated hospitalizations in select counties in 14 states. This covers approximately 10% of the US population. A patient must be a resident of the surveillance area and have a positive SARS-CoV-2 test within 14 days prior to or during hospitalization, and charts are reviewed by trained surveillance officers. The cumulative COVID-19 associated hospitalization rates by age are shown here. Overall, the hospitalization rate is 94.5 per 100,000, with the highest rates in people 65 years in age and older, with 287 per 100,000. COVID-19 associated hospitalization rates by race and ethnicity are calculated using hospitalized COVIDNet cases with known race and ethnicity for the numerator and bridged race population estimates for the denominator. The age-adjusted hospitalization rates by age and ethnicity are presented here. And non-Hispanic American Indian or Alaskan Native persons have a rate approximately 5.5 times that of non-Hispanic white persons. Non-Hispanic Black persons have a rate approximately 4.5 times that of non-Hispanic white persons. And Hispanic or Latino persons have a rate approximately 4 times that of non-Hispanic white persons. Overall, 91% of hospitalized adults had at least one reported underlying medical condition. The most commonly reported were hypertension, obesity, metabolic disease, including diabetes, and cardiovascular disease. 53% of hospitalized children had at least one reported underlying medical condition, and the most commonly reported condition among children was obesity. And finally, there was an MMWR published last week evaluating characteristics associated with hospitalization among patients with COVID-19 from 6 Metro Atlanta hospitals and clinics. There were 222 hospitalized and 311 non-hospitalized patients included. There were several factors that were independently associated with hospitalization, including age, 65 years of age and older, Black race, having diabetes mellitus, lack of insurance, male sex, smoking, and obesity. Next, I'll show COVID-19 epidemiology among specific subgroups. So first, for healthcare personnel, an MMWR in April described the characteristics of healthcare personnel with COVID-19. Among the cases reported at that time, 9,200 were identified as a healthcare provider. Among 1,400 healthcare provider patients who reported contact with a lab-confirmed COVID-19 patient in either a healthcare, household, or community setting, 55% reported having such contact only in the healthcare setting in the last 14 days. Most healthcare personnel were not hospitalized. However, severe outcomes did occur, including 27 deaths. CDC reports and routinely updates cases and deaths among healthcare personnel on the CDC website. As of June 23rd, there have been 83,000 cases and 464 deaths among healthcare personnel. For each of these at-risk populations, I want to highlight next steps and ongoing research to learn more. As data are available for each of these projects, we'll plan on sharing results with ACIP to inform future policy decisions. There are several projects ongoing related to healthcare personnel. The first is Project Covered, which is a prospective cohort study of healthcare personnel in U.S. emergency departments. The objectives are listed here, including estimating the attributable risk of occupational acquisition and risk factors for transmission. They'll collect serial symptom questionnaires, serology, and PCR over a 12-week period. There are also projects through the Emerging Infection Program, or EIP. These projects include surveillance for and interviews of healthcare personnel cases compared to healthcare personnel non-cases. As of June 12th, over 1,000 cases had been reported and 425 interviews had been conducted, and we'll share data with ACIP as soon as it's available. There are 2 additional studies, and the details are listed here. Both are primarily cohort studies over 12 months with repeat PCR and serology collected among healthcare personnel, first responders, and essential workers to determine the incidence of symptomatic and asymptomatic infections among these individuals. Next, moving to long-term care facility residents. There have been several published descriptions about a facility in King County, Washington. Through March 18th, there were 167 confirmed COVID cases associated with that facility. 101 were residents, 50 among staff, and 16 visitors to the facility. Overall, 86% of residents tested were confirmed positive, and 34% died. In this report, as well as experience at other facilities, shows that once COVID-19 has been introduced into a long-term care facility, it has the potential to result in high attack rates among residents, staff members, and visitors. There are many areas that contribute to the vulnerability of long-term care facilities, including familiarity and supplies of PPE, atypical presentations in the elderly, a high prevalence of underlying condition, and the fact that many facilities share staff and patients. This was highlighted in the journal article shown here, where numerous facilities in King County shared either staff or patients with the initial facility, potentially introducing COVID into those facilities as well. CMS released a rule on April 30th requiring all nursing homes certified by CMS to report data through CDC's National Healthcare Survey Network, or NHSN. As of the week ending June 7th, almost 15,000 nursing homes are reporting through this COVID module. The facilities reported over 107,000 confirmed cases, over 71,000 suspect cases, and almost 30,000 deaths in residents. CDC also tracks what states report publicly. These numbers include a broader range of long-term care facilities, and as of June 11th, there were at least 245 cumulative confirmed or probable cases in residents and staff, based on health department websites and other publicly available information. As mentioned previously, there's a COVID-19 module through NHSN, and the information collected through this will be used to strengthen COVID-19 surveillance locally and nationally, to monitor trends in infection rates, and help local, state, and federal health authorities get helps to nursing homes faster. Next is focus specifically on children. Children may have different or minimal symptoms compared to adults, including abdominal pain or GI symptoms, and they also may be more likely to be asymptomatic. In addition, there's limited information to date regarding the role children play in transmission. Early in the outbreak in China, while children were still in classes, school-age children had the largest number of close contacts of any age. The efficiency of spread in schools by children is unknown. Existing data are reassuring, but quite limited. One of the more concerning aspects of the COVID-19 pandemic has been the severe inflammatory disease seen among children. It was initially called the pediatric inflammatory multi-system syndrome and initially described in Europe. It presented with a Kawasaki's-like disease and cardiac involvement. Shown here in the figure is COVID-19 a hospitalization curve from France in orange and cases of the inflammatory disease in children in various shades of blue. The epi curve peaked 4 to 5 weeks after the peak of the COVID-19 epidemic in France, which could suggest a post-infectious process. A report from England described 58 children with fever and lab evidence of inflammation. 26% of those children had a positive SARS-CoV-2 PCR, and 87% of those tested were positive for SARS-CoV-2 IgG. Overall, 78% had evidence of current or prior SARS-CoV-2 infection. All patients presented with fever, over half had abdominal pain and rash. And in addition, half of the children developed shock or myocardial dysfunction, 14% developed coronary artery dilation or aneurysm, and 2 children required ECMO. A HON, or Notice Through the Health Alert Network, was released by CDC on May 14th, establishing a case definition for the multi-system inflammatory syndrome in children, or MIS-C, in the US. This case definition includes fever, lab evidence of inflammation, evidence of clinical severe hospitalized illness with multi-system organ involvement, and evidence of COVID, which could either be a positive PCR test, antibody test, or identified COVID exposure within the 4 weeks prior to the onset of symptoms. Information from MIS-C in the US has been collected through the Overcoming COVID-19 study, coordinated by Boston Children's Hospital and funded by CDC. There were 213 MIS-C cases enrolled at 53 participating health centers in 26 states. Most were previously healthy, with a median age of 8.4 years. 73% were PCR or antibody positive at admission. Cardiovascular involvement was prominent. 50% had an elevated troponin, 38% had an ejection fraction less than 55%, 50% required vasopressor support, and 9% had coronary aneurysms. And we know from experience with Kawasaki's disease that this has long-term implications when diagnosed in children. There are several surveillance systems CDC can use to monitor MIS-C. First, CDC recommends that healthcare providers report suspect cases of MIS-C to local, state, or territorial health departments. And these health departments can then record cases through NNDSS for case counts, and case report forms are submitted. Cases can also be assessed through the new Vaccine Surveillance Network, which consists of 7 pediatric medical centers, and COVIDnet, which was described previously. Next, to pregnant women. There can be physiologic changes in pregnancy that may increase the risk of severe illness, and severe disease has been associated with other viral respiratory infections in pregnant women. However, initial reports had been unclear regarding COVID's impact on pregnant women. Recent studies are helping to define this better. There was a recently published prospective cohort study conducted from mid-March to mid-April at 5 medical centers in New York City. There were 241 women with a positive SARS-CoV-2 test. Who was tested varied by medical center and over the time frame due to test availability, evolving epidemiology, and hospital policies. 89% were admitted for obstetric indications, and the remainder for GI or influenza-like illness. Over 60% were asymptomatic at the time of admission. However, nearly a third of those women developed COVID-19 symptoms during hospitalization. A body mass index of 30 or greater was associated with COVID-19 severity. However, insurance type, age, race and ethnicity, and other underlying medical conditions were not associated with COVID-19 severity. There were 236 live-born neonates that were tested for SARS-CoV-2, and 98% tested negative. The preterm birth rate in this cohort at 14.6% is higher than among the general population, with a statistically significant linear trend between COVID-19 maternal severity and the risk of preterm birth. Now I'll present information from an MMWR scheduled to be released later this week. From January 22nd through June 7th, there were over 300,000 cases of lab-confirmed SARS-CoV-2 infection in women of reproductive age, defined as 15 to 44 years, reported to CDC through COVID-19 surveillance. Of those, 28% had available data on pregnancy status, and of them, just over 8,200, or 9%, were reported as pregnant. This percentage may be affected by more frequent healthcare encounters among pregnant women, which increase opportunities to receive SARS-CoV-2 testing, missing pregnant status among women, or increased screening in pregnant women. A number of inpatient obstetric healthcare facilities have implemented universal screening and testing policies for pregnant women upon admission. Among pregnant women, 31.5% were reported as hospitalized, compared with 5.8% of non-pregnant women. After adjusting for age and the presence of underlying medical conditions and race and ethnicity, pregnant women were significantly more likely to be hospitalized with an adjusted risk ratio of 5.4%. Pregnant women were 50% more likely to be admitted to the intensive care unit and 70% more likely to receive mechanical ventilation. 16 deaths were reported among pregnant women in a similar proportion to non-pregnant women. There are challenges in interpretation of hospitalization as an outcome for severe COVID illness in pregnant women, as data are not available to distinguish hospitalization for COVID-19 from hospital admission for pregnancy-related conditions. Therefore, differences in hospitalization by pregnancy status may reflect a lower threshold for admitting pregnant patients or for universal screening of women admitted to a labor and delivery unit. In an analysis of outcomes among pregnant women versus non-pregnant women hospitalized with lab-confirmed COVID-19 from COVIDnet, the risk of ICU and mechanical ventilation was actually lower among pregnant compared to non-pregnant women, and there was no statistically significant difference in the risk of in-hospital death. While the reason for admission is not specified, it's possible that non-pregnant women were predominantly admitted for medical illness, whereas pregnant women were admitted for medical illness or labor and delivery. Pregnant women admitted solely for labor and delivery are likely healthier than pregnant or non-pregnant women admitted for medical illness. So in summary, this new report includes the largest US cohort of pregnant women with lab-confirmed SARS-CoV-2 infection. More complete data are needed to assess if SARS-CoV-2 infection in pregnancy is associated with adverse pregnancy or neonatal outcomes. However, results from this study do suggest an increased risk of ICU admission and mechanical ventilation, which are distinct proxies for severity, in pregnant women compared to non-pregnant women. However, the absolute risk of clinical interventions is still very low in this population. Regarding next steps in pregnant women, there are several cohort studies in development, including retrospective and prospective cohorts that will assess incidence and seroprevalence of SARS-CoV-2 in pregnancy, as well as severity of disease. Next, supplemental surveillance is being implemented to collect additional data on pregnancy and neonatal outcomes, and teams are leveraging existing pregnancy surveillance systems. So finally, COVID-19 among people in congregate settings. First, among meat and poultry processing plants, there were 115 plants in 19 states that reported COVID cases to CDC in April. In those settings, there were nearly 5,000 COVID cases, representing 3% of workers, and this ranged from 0.6 to 18% of workers by state, and 20 deaths were reported. Again, in April, there were 420 correctional or detention facilities with at least one case from 32 jurisdictions, with nearly 5,000 cases among incarcerated persons and 2,800 cases among staff. There were 88 COVID-related deaths among incarcerated persons and 15 among staff. And there were nearly 1,200 residents and over 300 staff members who were tested across 19 homeless shelters in 4 US cities from late March to mid-April. You can see that among shelters associated with a cluster, meaning 2 or more residents had tested positive for COVID in the prior 14 days, the percent of residents that tested positive ranged from 17 to 66%, while in shelters not associated with a cluster, there were much lower rates of infection. Next, for just a brief overview of some ongoing serology studies. There are numerous seroprevalence surveys underway or about to begin. First, large-scale geographic seroprevalence surveys to estimate the number of people previously infected with SARS-CoV-2 and not included in official case counts. These include specimens from commercial labs and blood donations. Next, there are community-level seroprevalence surveys that cover smaller areas, but where the selection of participants can be systematically selected. And finally, there are special population seroprevalence surveys meant to answer questions about specific populations, such as healthcare workers or pregnant women. So in summary, there have been over 2 million cases of COVID-19 diagnosed in the US through June. Multiple subpopulations appear to have an increased risk, including older adults, healthcare workers, individuals at long-term care facilities and other congregate settings, and those with underlying conditions. Many projects are ongoing to better define characteristics of SARS-CoV-2 infections, and we'll share them with ACIP once results are available. I also want to thank the many people through the Epi Task Force and CDC that helped provide data for this presentation, and thanks.
Thank you very, very much for that very extensive and clear overview of the epidemiology of COVID in the United States. So we're going to open this up for questioning. So let me begin, Dr. Oliver, by asking you my question, which is, so we have data you presented data through May 30th, but in the last few weeks, we've seen an increase in the number of cases reported. Can you tell us more about these cases and the numbers of states with the increases in cases?
Yeah, so the MMWR with the 7-day average was through May 30th. The rest of the slides were through June 13th. We publish a COVID view report that comes out every Friday that includes the previous week's data. So that was all through that published data. We're actually running the data today for this week's report, and that'll be published on Friday. And I'm happy to share that with ACIP. We'll share it so we can, and it's publicly available on the website.
Thank you. Any other questions from the voting members? Dr. Bell.
Thank you, and thanks for a terrific presentation. I wondered if you could reflect a little bit about plans going forward for sensitive surveillance at multiple levels. It seems like, especially in the context of flu season, that having a pretty sensitive surveillance system is going to be pretty important for control efforts.
Yes, we agree. And this summer, there actually have been multiple efforts to strengthen surveillance systems across U.S., leveraging existing flu surveillance systems as well, and diagnostics as well.
Dr. Szilagyi.
Yeah, thank you. Thank you for an excellent presentation. Just a couple questions. Regarding MIS-C, there are some anecdotal reports that in the United States, there's a big difference in the prevalence of MIS-C on the East Coast versus the West Coast. And I was wondering if you could talk about that, with thoughts about that, if there is. And then I had a question about pregnant women.
Yeah, regarding MIS-C, I know that there are kind of ongoing projects that are looking at trying to look at incidence and numbers kind of across the U.S. and by region. As it's a relatively rare outcome by now, we're collecting data and we'll continue to report data that's available as it becomes available.
Okay, thanks. And then regarding the large study about pregnant women and hospitalizations and ICU admissions, I mean, there's clearly a very strong hospitalization bias. I mean, there's many hospitals that test for COVID immediately upon hospitalization. But the ICU data and mechanical ventilation data were concerning. Do you have more information about the ICU or early in pregnancy, late in pregnancy, or any more information about the women in ICU with COVID?
Yeah, so the great news there is that MMWR, I think, is actually scheduled to come out tomorrow, which will have additional data that I wasn't, just due to time, able to present here, and they have some additional analyses included. I don't off the top of my head know that they broke it down by trimester of pregnancy, especially given that many of them were admitted for delivery. I think the data is kind of skewed towards later in the pregnancy, but I know that they're enhancing surveillance systems across the U.S. Through pregnancy, to collect additional data on that.
Thank you.
Are there any more questions from the voting members?
Dr. Romero, I think Dr. Oliver would like to just quickly summarize a little bit more the expected information that'll be coming out at the end of the week in terms of our COVID report. Dr. Oliver?
Yeah, sorry, I ended that a little early, but we're just trying to say that we publish reports at the end of the week, but acknowledge that through the data that had been published through last week, and then what we anticipate to see in the report this week, through because CDC is reporting daily case counts, we have seen an increase in cases that have been reported to in the U.S. Over the last couple of weeks across the U.S. And our surveillance systems are picking that up and will be included in reports moving forward.
Thank you. Any more questions from the voting members? Any questions from the liaisons?
Thank you so much for the presentation. One curious finding for me actually that stood out was the proportion of positive tests was higher among children, which I'm actually surprised by, given all that we've heard and seen to date around asymptomatics. So are those tests done in both symptomatic and asymptomatic children? And is there a reason that you think there might be an increasing trend towards the proportion of test-positive children, especially with regard to opening of summer camps and schools and things like that? Do you have any thoughts on that?
Yeah, thanks. So the current lab systems where we're getting through CDC do not have the ability to distinguish between symptomatic and asymptomatic infections. We're hoping to enhance that kind of moving forward, but we can't look back and say who is symptomatic and asymptomatic. And if you look, it's less that they have been increasing in recent weeks and more that they've kind of held steady as other things have declined. We think this is likely multifactorial, but it likely just represents that they're a very unique population. Given that they have such a small proportion of tests done, it also could just be that the pretest probability of who's being tested is a little bit higher. But I definitely think we're trying to look into and figure that out across the U.S. as well.
Thank you.
Opening it up to other questions, liaisons. Okay, there doesn't appear to be. So we will move on to our next speaker, Dr. Melinda Wharton, who will talk about routine pediatric and influenza vaccination in the setting of COVID-19. Dr. Wharton, please.
Thank you. I'll be providing an update on our work on routine childhood vaccination during the COVID-19 pandemic, as well as the planning we're doing for the upcoming influenza season. Next slide. In mid-March, there was a precipitous drop in ambulatory care visits, as shown in the yellow line on this graph, as stay-at-home orders were issued around the United States. There was some recovery that we see in early May, although the number of visits remained well below baseline. Next slide. Pediatrics was among the hardest hit specialties with this reduction in ambulatory care visits, with a 62% reduction by the week of April 5th. Next. By the week of May 10th, there had been some improvement in pediatric outpatient visits, with the least reduction seen in visits for children under 2 years of age and the most for children 3 to 5 years of age. Next. The Vaccines for Children program provides federally purchased vaccines for eligible children in the United States. In order to assess the impact of these reductions in outpatient visits on childhood vaccination, we looked at weekly VFC vaccine orders for all childhood vaccines other than influenza vaccine in 2020, in the orange bars on this graph, and the comparable week in 2019, illustrated in the blue bars. The slide shows a dramatic reduction in vaccine orders beginning in mid-March, extending into early May. Next. This graph shows VFC orders for measles-containing vaccines. We see a similar pattern as the previous graph, but the reductions are even greater than in the previous figure. Next. Also during this time, many medical practices were under severe stress as patients were not being seen, staff may have been furloughed, and some practices closed temporarily or unfortunately permanently. Next. With partners, we've undertaken a number of activities to support recovery of routine childhood vaccination. In addition to monitoring service delivery, CDC has developed guidance on routine vaccination, the importance of well child visits, and safe vaccine delivery. We've encouraged state immunization programs and healthcare practices to encourage catch-up vaccinations through reminder recall systems. With our state partners, we're looking for gaps in the VFC provider network and through the budget process, planning for a potential increase in the VFC eligible population. With partners, we've worked to identify policy interventions to support healthcare providers. On the communication side, we've supported efforts to communicate about the importance of well child visits and routine childhood vaccination to parents, providers, and partners, as well as raising awareness about the VFC program for families that may be newly eligible. Finally, it's really critical that we address catch-up now to allow us to move on to back-to-school vaccination in the summer and influenza vaccination in the fall. Next. Initial support for healthcare providers through the Provider Relief Fund was directed to providers participating in Medicare, but since June 9th, providers participating in Medicaid and CHIP have been included. We've continued to promote catch-up vaccination and reminder recall activities and have refocused our immunization program quality improvement activities on catch-up vaccination. We've also provided guidance to providers on safe delivery of vaccines during the COVID-19 pandemic. Next. That guidance identifies vaccination as an essential medical service for all children and adolescents that ideally should be delivered in the medical home. All due or overdue vaccines should be administered according to the routine immunization schedule during the same visit, and strategies to catch up patients on vaccines they missed should be implemented, starting with the youngest children and extending through adolescence. The guidance also addresses safe delivery of vaccines, including use of personal protective equipment and physical distancing. Next. Our communication efforts are focused on encouraging parents to return for well child visits, encouraging use of reminder recall systems to get children up to date as quickly as possible, and encouraging providers to share with families the safety protocols put in place to ensure that children can be safely seen in the clinic and vaccinated. Next. We've also been working with partners to promote awareness of the Vaccines for Children program among parents. Prior to the COVID-19 pandemic, about half of U.S. children were eligible to receive federally purchased vaccine through the VFC program. More children may be eligible now due to parents' loss of insurance coverage. These families who have newly eligible children may not know about the program, and we appreciate the support of partners and providers to increase awareness about this critically important program. Next. We've created resources for communicating with parents, as shown on the slide, and the American Academy of Pediatrics has developed a very shareable social media campaign directed at parents using the hashtag #CallYourPediatrician. Next. Since May, we're pleased to have seen improvement in the weekly vaccine orders from VFC providers. When we look at the individual vaccines, the recovery is greater for vaccines given to infants, like HIB, and less for vaccines given to preteens and adolescents, like HPV, which shows there's still room for improvement, although things are moving in the right direction. Next. Looking forward to summer, many children need to receive vaccines during the summer to stay up to date and comply with school vaccination requirements. It's really important that the back-to-school vaccine clinics take place this summer to provide children an opportunity for vaccination. In the event that COVID-19 circulation disrupts those back-to-school vaccination efforts, we'd encourage jurisdictions, if possible, to allow additional time for compliance rather than suspending school requirements completely through some sort of emergency action or creating a situation where families feel like they need to seek exemptions. Next. Now moving on to planning for the upcoming influenza season. Next. As was presented this morning, the influenza season that just concluded was characterized by an initial wave that was predominantly influenza B, followed by a later wave of influenza A, H1N1. As of June 13th, 185 deaths of children associated with laboratory-confirmed influenza have been reported to CDC. CDC estimates that in the 2019-2020 season, there were, due to influenza, millions of illnesses and medical visits, hundreds of thousands of hospitalizations, and tens of thousands of deaths. Next. Because we expect that SARS-CoV-2 will continue to circulate into the fall, influenza vaccination will be an important strategy to decrease stress on our healthcare system by decreasing doctor visits and hospitalizations, as well as decreasing the number of people who will need diagnostic testing. Given the risk groups that have been identified for COVID-19, influenza vaccination will be particularly important for staff and residents of long-term care facilities, adults with underlying health conditions, African Americans, and adults who are part of critical infrastructure. Next. There are longstanding disparities by race and ethnicity in vaccine coverage with influenza vaccines. This slide shows data from the 2017 National Health Interview Survey. Influenza vaccine coverage was lower among Hispanic and Black adults compared to white adults in all age groups and among groups with and without underlying high-risk conditions. Next. In planning for the upcoming season, we're pleased that manufacturers of U.S. licensed influenza vaccines are planning a record high amount of vaccine with more than 180 million doses expected. We will need effective outreach to persons at higher risk, planning for the potential need for social distancing and vaccine delivery, and planning to extend the influenza vaccination season until December or later for distribution of all doses that are expected. Ongoing COVID-19 prevention activities provide opportunities to share influenza prevention messages, and we'll need to focus on African American and Hispanic communities given the disparities in influenza vaccine coverage and COVID-19 morbidity that's been seen. Next. We're also pleased to have been able to provide supplemental resources for public sector influenza vaccination for the 2020-2021 season. This includes supplemental funding to support immunization program activities and purchase of additional vaccine for use in adults. In most years, we have purchase of about 500,000 doses for adults through our federal contracts. This year, we've been able to purchase an additional 7.1 million doses. Some of these doses will be available late in the season, so it will be especially important that the vaccination season be extended into December or later. Community health centers provide an important partnership opportunity for state immunization programs to reach adults who otherwise might not be vaccinated. We appreciate the support and collaboration of the National Association of Community Health Centers in facilitating these connections with our state programs. Next. In conclusion, there have been substantial disruptions to routine childhood vaccination services and well child visits during the COVID-19 pandemic. We do see evidence of movement in the right direction, but we aren't done yet. We need to get children caught up as soon as possible so we can move on to back-to-school vaccination efforts and then influenza vaccination in the fall. We need solutions to our existing disparities in influenza vaccination coverage in order to avoid these disparities if possible when we have a COVID-19 vaccine. And we appreciate the support of immunization programs, partners, and healthcare providers in getting childhood vaccination back on track by supporting catch-up vaccination efforts and communicating with parents about safe well child visits and vaccination during the COVID-19 pandemic. Next. Thank you. That concludes the presentation.
Thank you very much, Dr. Wharton. I think we have time for one or two quick questions. Anybody from the voting membership?
It looks like Dr.
Bell.
Thank you. Dr. Wharton, thank you so much for that presentation. I just wondered if you could sort of quickly, I know there's been a lot of effort and research put into understanding the reasons for the racial ethnic disparities in influenza vaccination coverage among adults. But I just wondered if you could reflect a little bit on what is clearly multifactorial, but what some of the major drivers of this disparity appear to be.
Thanks, Dr. Bell, for that question. It is, as you note, a complicated and multifactorial issue, no doubt. And I'm not sure I've got a very satisfying answer to it. It clearly goes way beyond access. There's strong evidence of differences in vaccine perceptions, acceptance of vaccination by race, ethnicity, perceptions of the need for vaccination, and trust in recommendations from healthcare providers. That all of those likely contribute, and I think the question is one of the things I think we're very interested in is we know that quality improvement efforts, things like standing orders, prompts, strong provider recommendation, those sorts of activities that we know work to improve vaccine coverage among both children and adults, whether or not those will be sufficient to reduce disparities. And we're really pleased to be doing some ongoing work in association with the National Association of Community Health Centers to try to get a better handle on to what degree we can address disparities through quality improvement or whether or not additional strategies will be needed. This is a current focus of a good deal of work at CDC right now.
Thank you. Let me have Dr. Paling ask her question, and then we'll turn to Dr. Pam Rockwell and Dr. Goldman. Dr. Paling.
Hi, Kathy Paling. Thank you for a great presentation that really outlined the impact of the stay-at-home on the vaccine coverage for children. It was very well done. One of the things I wanted to ask is the data you showed on vaccine disparities was focused on the adults, and I wanted to give you an opportunity to talk about the vaccine disparities we see in children as well.
Thank you for that question. Fortunately, the disparities we see in children are much, much smaller. They're not non-existent, but they are much smaller in magnitude than we see with adults. And I think we really have both the Vaccines for Children program as well as the commitment of public sector immunization programs and participating healthcare providers to really try to make sure that vaccines are available to everybody. And so again, it's not that they're completely absent, but they are substantially less than we see with adults.
Dr. Rockwell?
Yes, thank you. My question actually was about the previous presentation on immunology, but I have thought of one for Dr. Wharton as well. Dr. Wharton, the messaging that you spoke about that we need to focus on for African American communities and Hispanic communities, is that something that the CDC will be working on and putting out a statement, maybe in alignment with other national organizations that might confer more trust with those communities? Or is that something that we should just focus on as individual physicians talking with our patients?
Thank you for that question. There is some research that's going on to help inform communication efforts. There's some external partnerships with other organizations that are also working on this. And we have some other activities going on this summer that I think will help inform future activities. So stay tuned on this one. I think there'll be more to come in this particular topic.
Thank you for that. And I don't know if I can put out my question about the epidemiology for SARS-CoV-2, but my question was about BMI. And I noticed that, higher BMI had been associated with higher morbidity. And with the pregnant women studies, it was specifically stated a BMI over 30. I wonder if the same BMI number can be cited for children and then for non-pregnant adults.
Yeah, so underlying conditions, including obesity, is in the COVID-19 population, and I think that's actually a BMI over 35 instead of a BMI over 30. The BMI over 30 study was done in New York City, not through CDC. But yes, that data is being collected in children and adults through CDC.
Thank you. Dr. Goldman?
Yes, thank you, Jason Goldman, American College of Physicians. Excellent presentation. Really appreciate you highlighting and drawing attention to the issues in the pediatric population. But I would also put a plug in and like to ask that we look at the adults and perhaps some ad campaign education materials similar for adult medicine, because we too are facing the same issues of patients not wanting to come into the office, not feeling it's safe, decrease in adult vaccination rates, people staying at home. So we need the help as well in adult medicine with the marketing, the literature, the education, similar to the children as well. But thank you for all you're doing.
Thank you. Appreciate that point.
Dr. Whitley Williams, please. And that will be the last question.
Thank you very much. Pat Whitley Williams, National Medical Association. Thank you, Dr. Wharton, for that presentation. And regarding the disparities during this COVID-19 pandemic, we understand the existence of the comorbidities as well as the social determinants of health, but the communication strategies are so important. When we think what happened during the pandemic, the barbershops, the beauty salons, the churches were closed, at least in the Northeast area, New York, New Jersey area. And sometimes those places serve actually as a source of information and communication to the community, as well as what's in social media. So I applaud your efforts in terms of looking at the different strategies to get the word out. I'm very concerned about, as I'm sure other people are, regarding the distribution of vaccines when a COVID vaccine does become available, and whether there will be the structure in place to reach those that may be at greatest risk, but are also maybe more difficult to reach. Thank you.
Thank you for those points. Those are issues that we share your concern about and are trying to plan accordingly. So thank you.
Thank you. I'm very sorry. I see that there's still a hand or two up, but we have to move forward. We're already running over time. So we're going to take a break now, 5 minutes exactly, and we'll be back at 25 after the hour. Thank you very much.